Alrighty, well, we'll go ahead and get started today. Thank you all for being here. Welcome to our Introduction to Telehealth Echo series that we're holding in partnership with Renown Health. Glad to have you back, some familiar faces again. So thank you for being here today. We'll go ahead and get started as we usually do with introductions of our team and our subject matter experts, then on to all of you joining us out there today. So hello again, everybody. I am Troy Jorgensen, Program Manager for Project Echo Nevada. Mitchell?
Hi, everybody. I'm Mitchell Fong, Director of Telehealth here at Renown Health.
Thanks, Mitchell. Jessica?
Hi, everyone. I'm Jessica Thompson. I'm the Manager of Telehealth here at Renown.
Thanks, Jessica. Mike?
Hi, my name is Mike Howitt. I'm the Supervisor of Telehealth here at Renown Health.
Thanks, Mike. And Crystal?
Hi, I'm Crystal Larson. I'm a telehealth coordinator here at Renown.
Thanks, Crystal. Already, that's our team from Renown, now our Echo team. So Sneha, please go ahead.
Hi, everybody. My name is Sneha Sharma, and I am the Program Coordinator for Project Echo Nevada.
Alrighty, so now on to all of you joining us out there. Deb Arno, please go ahead.
Hi, my name is Deb Arno. I am a psychiatric nurse practitioner. I work in the medical school's behavioral health clinic, and my primary and only assignment now is doing telehealth through the state rural system with Ely, Nevada.
Thanks, Deb. Welcome today. Good to see you again. Amber?
Hi, I'm Amber Batchelor. I'm from the Nevada Coalition to End Domestic and Sexual Violence.
Thanks, Amber. Great to have you back. Dr. Greenberg?
Hi, I am Wesley Greenberg. I teach on the family medicine residency up here in Reno.
Thanks, Dr. Greenberg. Great to see you today. Hannah?
Hi, everyone. I'm Hannah Barnhart. I'm the Nevada Genetics Navigator for Mountain States Regional Genetics Network. And my internet's really slow, so my video's off.
Thanks, Hannah. Great to have you back today. Katie?
Hi, guys. I'm Katie Day, and I'm the Policy Specialist with Nevada Medicaid, and I oversee the telehealth policy.
Thanks, Katie. Welcome back. And Jude?
Hello, I'm Julian. I'm one of the telehealth coordinators for Renown Telehealth Program.
Thanks. Welcome. All right, great group. Thank you all for coming back. Good to have you again with us here today. This is our second to last session. We've got one more in a couple of weeks on September 9th. So glad to have you continuing on with us here. Alrighty, so I will turn it to Mitchell and Jessica for our didactic today. Jessica, I know you'll be sharing screens, so you should be able to pull those slides up.
Yeah, and as she's pulling them up, I'll just go ahead and get started. And thank you guys all for, again, joining us again. This 4-part series, we started with really what does it take for telehealth? What is telehealth? Last session, we went with technology requirements. What are the requirements for telehealth? How do we evaluate different technologies and different platforms? And today we'll be taking that one step further. Is as you get started, it's not just about selecting the right technology and making sure it's the right fit, but it's also about setting your staff and your team up for success. How do you train the clinicians? How do you train your staff? And how do you ensure that you have that set up in a meaningful way? And so just we'll just be moving into that. Just, I don't know if you are able to see, but it looks like we're showing the whole slide deck here. I don't know if you want to show just the presentation view.
One second, because on my side, I'm doing the slide deck, so hang on.
All right.
Jessica, if you're using 2 monitors, you might have to switch. It says like what, presenter view or something like that, or you might have to drag it over and select the right one if you put it full screen.
Let me just get back here. Hang on. Please bear with, I'm used to Teams, Troy, sorry.
This is the beauty of technology, is you have to be able to adapt when this fails. And one lesson learned here today is make sure you always have downtime procedures. Doesn't matter what's happening, you have to plan and expect the unexpected. And so a lot of times it's actually good to see technology fail in some of these presentations and demos because you know that you can resolve it quickly. And so as Jessica is troubleshooting that, I'll just go ahead and continue moving through the presentation where we always start with our disclaimers. Everything that we say and share, it's our opinions, our perspectives from what we've learned throughout our time in the area of telehealth. We will be using Renown Health as an example of what we've seen. And a lot of times we'll refer to that just because that's the program that we run. But again, it's our opinions. And so for me, just to provide some perspective, I did my master's research on the need for telehealth in rural Nevada back in 2011 to 2013. So for me, it's not something that just came up because of COVID and nature of where we needed to move in healthcare. It's something that I've been extremely passionate about for a while. And you may hear me throw out some information there that is just from experiences that I've had, conferences that I've gone to, or other experts in the area that I've really been able to learn from. And so with that, we kind of already gave our introductions, but we'll have two speakers besides myself today. We'll have Jessica and Crystal. Jessica is the manager of our program here at Renown, and Crystal is a telehealth coordinator. The way that we think about those different roles, the telehealth coordinators, they really set up the team for success. They do the training, but they really manage the day-to-day operations of how our team flows, our network. Jessica really, as a manager, manages the week to week to month to make sure we're planning for what we need to hit our deliverables. And then for myself as a director, I really look at the month to multiple years out. And so that way we're working together, breaking down the requirements, responsibilities to ensure that we're meeting the need today, tomorrow, and the future. So for our agenda today, we're going to walk through just, again, a quick snippet recap of last week, or 2 weeks ago, I should say. Then we'll talk a little bit about how do we onboard our partner sites, how do we provide the training to our providers and our care team, and then furthermore, how do we continue to use what we have in place and process improvement techniques to get better every day, knowing that technology continues to evolve, programs continue to change, and workflow is extremely important as we get there. And we'll save some time at the end for Q&A, but we really want this to be as meaningful and useful as we can. So we'd love if you guys are able to raise your hand, put in the chat bot, ask questions, however, whenever you have them, so we can address them in the moment. And let me just pause really quick before I start recapping this technology slide. Are you all able to see any slides currently?
Yeah, Jessica, yeah, it's just telling us that it's just giving us a black screen, sorry.
I don't know, Mitchell, on my end, it's showing that I'm showing the presentation.
Okay, I stopped sharing. You might just have to reshare again and we'll see if that works. Sometimes it just sits in this loop of like thinking you're sharing and just being the black screen.
Okay, let's try this again here.
We know what we're doing, folks, I promise.
How about now?
There we go, that's it.
Okay, you can see the agenda screen?
Yeah.
Wonderful, thank you.
Perfect. So let's move to the next slide. Thank you, Jessica and Troy, for that help. Where we're at here is just to highlight this. I think was a great table that Mike presented at our prior session about what is the minimal viable technology requirements for telehealth, and then what do we really recommend. And of course, you're going to want to work with each of those partners, not just vendors, but partners, to understand their systems to make sure this meets that requirement. But generally speaking, what we've seen industry-wide, the recommended here is standardized. Of course, if you can go above and beyond, that's better. Just like using wired connection is more reliable than using wireless. But if wireless is all you have, then obviously you have to do the best that you can in that moment. So with that, I'm going to go ahead and move to the next slide and pass it over to Crystal to talk a little bit about how do we onboard new partners, particularly for their staff and those providers? How do we help them get trained up? What's the type of training? And what are some of the tips and tricks that we use to make sure that they're ready? So Crystal?
Thank you, Mitchell. The key to setting up telehealth teams for success is training and continual re-education. Telehealth is constantly evolving, so it's beneficial to provide education as the programs transition. Each individual learns differently, so being able to adapt to the trainees' needs is important. What we have learned is that some teams prefer in-person training where the team can physically touch the equipment, where other methods of training are connecting virtually and presenting a mock patient. Virtual classes can also be used for training. This allows education to be provided with flexibility of completion. Selling points for the staff to become engaged in telemedicine training may be to obtain a certificate upon completion. Tying back the training to the who, what, where, when, and why we use telehealth is also very important to the trainee to understand. Website manner is also key. When training clinical staff, we often hear of the term bedside manner, but we like to challenge the clinical teams to think about website manner as well. Think about what is appropriate attire that should be worn, positioning of the camera, or incorporating important details like introducing yourself to the patient. Later on in the presentation, Jessica will go over website manner a little bit more in detail, so I'll wait till then to go into further detail. And then another item that is very beneficial is having an agile mentality. We try to train with the hope of enabling the telehealth members to have an agile mentality. We want the staff to be able to adapt to unpredicted situations with confidence. For example, the ability to shift with technology like we saw today, or to adapt to unknown or unexpected outages or staffing issues. Or like this last year with COVID, many providers or patients were unable to travel due to quarantine. Do you mind clicking to the next slide?
And as you do that, just one thing on that last one is there's a bullet point on leading with conviction and persistence. And a lot of that has to do with stigma and provider adoption, kind of going back to one of our first sessions that a lot of providers that are delivering care virtually today did not go through medical school or their clinical training with telehealth available. So we have to really think about how do we push forward, how do we be persistent to engage these providers and listen to what the concerns are to make sure we can address that. The real key point is that we don't want to sacrifice any quality with anything that we're able to deliver, but that's why the technology has to be easy and convenient, and really why website manner is so important when you're having that interaction. And I'm sure because we've all been on these virtual meetings now more and more commonly, we've been able to see what we think is positive body language versus negative body language when you're in a meeting. And just think about how a patient would feel if they don't believe that the provider is treating them with that same level of respect, the same level of attention as they would if they were sitting directly in front of the patient in the clinic. And so I think that's a big part of what we say when we say lead with conviction, website manner, and really make it easy for them. Sorry, Crystal, I just wanted to add that to it.
No, I think that's great points, Mitchell. Next, we want to go into kind of a little bit how to market the education for telehealth. So marketing is a very good tool to help utilize for that education. For example, when one of our rural sites started participating in telemedicine, the town put out an advertisement in their local phone book. Many people actually came into the clinic referencing the phone book ad and wanted to learn more about the telemedicine program. Sometimes you have to be creative and think about your audience. In this case, the audience was a rural community that was used to looking in a phone book rather than picking up their phone and maybe Googling information. Another idea that we use is the train the trainer model. Identify key team members that can participate in advanced training and that they can take accountability for helping train other team members is very important. Provide an open line of communication to those teams. Allow them to express what has worked well for them and what struggles they have experienced with telehealth. And engage those partners to collaborate on training tools or training videos. Include all integration points in that training. That may include scheduling referrals or IT teams at these partner sites. We want to be able to have any participant feel enabled to have a voice in the program and be able to speak up on what they think and have learned through their process. Next slide.
And as we do that, the train the trainer model is extremely important because we think about how do we become more efficient, how do we become more effective, and then secondarily, it's how do we ensure we have coverage, backup. A lot of times what we see is there's one single person trained to be a presenter, or there's one coordinator there. But when that person's on vacation, when they're out on leave, or they're out on lunch break, or emergency comes up, there isn't anyone trained to do the backup. And that sacrifices patient services, because then we have to reschedule that patient that already was planned to come. And who knows how far out that technically could be for a delay. So train the trainer is important for multiple reasons. One, because it prevents any delay in care. It goes back to being that agile mentality of being able to lead with anyone, whoever's in the room. But then furthermore, it allows you to broaden the horizon of telehealth to really address that stigma over time. The more people that are trained to use this, the more efficient and effective it'll be. And the more that we can use this interchangeably across our teams and our staff. So that's really why we think about that train the trainer model and allowing them to provide that feedback so we can always get better.
Thank you. One of the additional key points that we often think or sometimes overlook is setting up patients for success. Telehealth for many patients is something new to them. We always want to ensure that the patient feels comfortable and understands what is going to take place during a telemedicine visit. What we have learned is that providing patients with educational materials prior to their appointment helps to ease their concerns on how to use the technology. Using tip sheets or training videos to help connect to the visit are also a good idea. Additionally, pre-visit workup. Informing patients during the scheduling process if they are needing to complete ancillary services, pre-visit paperwork, and what else is to be expected of the visit during for the patient is also very beneficial. Communication reminders. As you may know, sometimes appointments are scheduled several days, weeks, months in advance. So sending communication reminders to the patients are very beneficial. Some examples of how you can send reminders to patients could be in emails, mailing, text messages, or phone calls. And then also testing connections. Reminding patients that will be joining virtual visits from their personal devices to test their connections, ensure that audio and visual are working without error, and also to ensure that their internet can support a virtual appointment is very helpful. This will help ensure that the appointment can be completed, and it also prevents troubleshooting at the time of the appointment. Before I hand back the presentation to Mitchell, I'd like to pause and see if there are any questions on the slides that you just reviewed.
Yeah, any questions at this time? Feel free to unmute yourselves or write into the chat box, please.
Thank you.
And as we're waiting, we'll give it another minute or two for questions. I'll just add on part of that pre-visit workup. It's not just telling the patient what's needed, but it's guiding the patient to where we can be successful, right? So if they need to get, let's say an EKG done prior to a cardiology visit, where's the closest place they can get it? Do they need to schedule an appointment? Can we assist with scheduling that appointment if so? So I think putting those tools in their toolbox is what we want to do, is guide the patient to the right place so they can get that care. Furthermore, for some of these things, and particularly in our next session, we'll talk a little bit what's the future of telehealth. We're going to see a lot more home-based imaging, home-based diagnostics that can be done. Are we able to send this to the patient's home? Is that what they prefer if they want to do a home EKG? So there's different ways that we can think about how do we support the patient best and customize the care for their needs. We have to understand what their limitations and their barriers are. And that's a big reason why I think Crystal alluded to communication. You may want to use different modalities, whether it's text, call, email, physical mail letters. And I think the phone book example was a really good example of sometimes we still have to meet the patient where they are, even if in our areas, I know I don't look at phone books anymore, but I live in a different community, and that's just my personality as a patient. That would be my profile. So we really want to make sure that we're setting them up for success as much as possible in advance and walk them through the test connection. We had a team, we learned from this during COVID, that very quickly wanted to turn on and ramp up the volume because we couldn't have patients in office. And one of the concerns with it was our patients didn't know how to join the visits. They didn't know how to go to my chart and launch the Zoom visit at that time. And so we created a team that actually would assist patients, a call in line, as well as a proactive reach out that would test connect with these patients to show them how to walk through the MyChart, log into MyChart, and then launch the visit from there. That way we can test the device, coach them through the process, and make them more comfortable. Again, we have to imagine being in the patient perspective. Anything new, particularly when I'm already sick, makes me afraid, makes me nervous. How do we help address that mental health stigma so they don't feel anxious or anxiety just to get connected to the appointment? I liken that to the whole idea of removing that waiting room experience, is we don't want patients to feel like a number in a room with other sick people. But if we're not helping them feel like they're successfully connecting, many of them will just prefer to go sit in that room and wait. But we can make that experience so much better for them.
Thanks, Mitchell. I think you just shared a great example. Hannah wrote something in the chat box saying, also remember to include family members in the communication if the patient isn't tech savvy. So you shared an example there of how you could kind of help a patient if they're maybe not familiar with technology. Could you share a little bit more, or maybe somebody else on your team? If you could include a family member to support in those things.
Yeah, absolutely. We do have the option to add in family members, caretakers as a part of this. What we like to do too is ask those patients and try to, again, proactively contact them to see what support that they have in their home. I'll say firsthand example, again, going back to during COVID, one of the benefits of having everyone at home was that grandparents were around the grandchildren. Grandchildren were using Zoom for school, so they were able to assist their grandparents in getting connected for their medical appointments. From there, we created some tip sheets to send out and provide them guidance and help. But I don't know, Jessica, Crystal, if you want to expand any more about how we've been able to include some family members and caretakers in the support system.
So some ideas that come to mind for me, Mitchell, is when presenting telemedicine, we generally will allow family members into the room with the patient. And it's something I'm going to kind of review downstream in this slide deck, is that, you always have to remember that camera can only see a certain view within that room the patient sits in. So always be mindful to ask if there's anyone else in the room, introduce them to the provider or to the patient if the provider has somebody else in the room. Always include everyone that's in that room. So that's one way to include family members. Also with our MyChart for Renown specific, I know other EMR systems have patient portal. We do have proxy access for patients to request to have access to that MyChart for a grandmother or a grandfather or a child, so they can be interactive with that patient's care as well.
Thank you, Jessica. So as we move to the next slide, I think Jessica will cover a little bit about policies, tips, tricks, training, and then I'll bring us home at the end with just kind of what's the value and how do we use these things to ensure that we're delivering the right service at the right time. And so Jessica, I'll give it to you here.
Thank you, Mitchell. So now we want to move into policy and procedures for your telemedicine program. So I'd like to take this time to review some of those policy and procedures that we feel are valuable to have and that will help ensure that your telemedicine program will be successful. And when we start thinking about policy and procedures, the first thing that comes to mind is compliance and accountability. Policy and procedures are an essential part of any organization. They provide a roadmap for day-to-day operations, clearly defining and setting the expectations for staff. They ensure compliance with laws and regulations. They provide guidance for decision-making and streamline processes, thus holding everyone accountable. One of the first policy and procedures I'd like to touch on is billing requirements. As we all know, telemedicine does have a different set of billing rules and regulations, and most of this is governed by CMS, which is Centers for Medicare and Medicaid Services. They do have a set requirement that must be met for billing telemedicine services. If these requirements are not met, payment may be held or denied on a claim. And I'm going to cover the specific requirements for billing a little later on in this presentation. The next one is standard workflows for efficiency and process improvement. The first one here is documentation. Documentation standards should be set by your organization. Documentation templates can also be built into your EMR to provide consistency, allowing you to set standards on what is to be documented for each telemedicine encounter. Service level agreements. These agreements hold both parties accountable. They define the level of service that the end user expects from the service provider. An example of an SLA would be a telestroke services or originating site outpatient services. Special handling instructions. This is information provided by an end user to a service provider. It provides updated contact and scheduling information, can include but not limited to items such as hours of operation, departmental contacts, special considerations for scheduling appointments. You can make this what you want. It's to include all the information that your program needs to successfully interact with a partner site and to schedule appointments for that specific site. And then URAC accreditation. URAC, which is Utilization Review Accreditation Commission, is the gold star standard for healthcare accreditation. This demonstrates commitment to upholding and improving outcomes in the telehealth field. This should be a goal all telemedicine programs should strive for. And here at the bottom of the slide is an American Telemedicine Association quote that can be a resource for guidance on policy and procedures. So you can read that. The policy principles of the ATRA are rooted in its vision. We promote a healthcare system where people have access to safe, effective, and appropriate care when and where they need it, while enabling clinicians to do more good for more people. And as we move into this next slide, we're going to review a few more of those policy and procedures. Another one is technology requirements and approved platforms. You want to, when you're thinking about developing these policies for your program, you want to make sure when you're thinking about technology, you want to utilize only approved equipment that has gone through rigorous review and testing by your telehealth program and IT support services. They will delineate which platforms have been approved for use by the organization. Always want to ensure that you're providing patient privacy, utilizing secure encrypted devices and platforms. Training requirements and standards. Ensure all staff have been trained to the same set of standards so your program will be consistent and uniform across the board. Create tip sheets and videos for staff training. It's always beneficial, as Crystal mentioned earlier in this presentation. Onboarding and offboarding procedures. Once again, this will ensure consistency among your program. Develop standard work as a guideline for these procedures, safeguarding your program from such things as missed trainings, licensure acquisition, missed access requests, or inappropriate template builds. An implementation guide. This is a step-by-step guide on how to implement a new site or partner site, whether it be an originating site or a distant site. This guide will walk you through every step to be taken to ensure a successful implementation to go live. These guides direct the entire implementation process from initial communication, equipment acquisition, training, go live, to the first post-implementation follow-up. Telehealth Handbook or Practice Guide. This would be a complete overview of the entire telemedicine program, including the program history, description, mission statement, contacts, services offered, recommended equipment, and platforms. This can be used as a quick reference guide for partner sites needing information regarding your program. Service level agreements. Once again, SLAs. They define program structure and process flow for each service line offered. Criteria for telehealth algorithm and conversion rate. Create a standard when determining which type of visit is most appropriate and beneficial to the patient, whether it be a virtual visit with no peripheral devices, a telemedicine visit with peripheral devices, or an in-person visit. Some things you must take into account when determining which visit type is most appropriate and beneficial to the patient and provider are diagnosis, insurance approval, patient location, type of exam required for the symptoms. Once these algorithms are developed, you will want to monitor conversion rates as they will be driven by the algorithms. For example, the number of referrals coming in that are converted to telemedicine visits. This helps ensure the patient receives the right care at the right time, at the right place. Credentialing and proxy privileging policy. This streamlined process permits the facility receiving the telemedicine services to rely on the privileging and credentialing decisions made by the entity providing the telemedicine services. This policy defines how the credentialing and privileging is conducted and by whom. With proxy privileging, it states who the responsible party is for the type of credentialing and how and when this information is shared with medical staff at contracted partners' sites.
And why that's so important for us in Nevada in particular is, I know credentialing, it typically is going to fall under your hospital-based, units. And people ask, well, why do you need that for telehealth? We're doing a lot of outpatient services for this. Well, when we think about those rural communities, a lot of their outpatient departments are actually hospital-based departments, which means any provider delivering care, even outpatient only care to that clinic, fall under the hospital credentialing rules. And so for those rural hospitals, they may only have 1 or a half FTE that's working on credentialing and privileging all providers across the system. And you think about a network that has, let's say, 10 cardiologists rotating through telemedicine to that site. Well, how much burden or work is that for that rural site to get those 10 providers credentialed? It's significant. And so the ability to have that proxy agreement where we can credential them from one site, but pass that credential and privilege on to our rural partners, that's extremely beneficial for them to tap into and use those resources consistently. And as Jessica was talking a little bit more about the guides and the implementation, we really think of that as bringing some structure and rigor to the process, where it's kind of a project management tool that outlines the expectations, requirements, but also gives you a guide to walk you through the process as to making sure every box is checked and we're ready to deliver care, receive care, whichever it is. But that's also why it's very important that you have some of those things in place. And I know Jessica's going to go into here some policies that are often overlooked. Some of them are very similar to the common policies and procedures. We just wanted to call some out that we've heard of around the country that organizations have forgotten about or had to implement later. And so we just wanted to bring them to your attention up front.
So as Mitchell said, we're going to now review some commonly overlooked policy and procedures. Science and technology during COVID. During the pandemic, we have seen a drastic increase in telemedicine use. With this, there are many platforms out there to utilize when conducting a telemedicine visit. This type of policy will help ensure providers are not utilizing non-approved platforms for these visits. This keeps a tight rein on what technology and platforms that personnel throughout your company can utilize efficiently and safely. Documentation, billing requirements, and level of service. As we've kind of mentioned earlier, documentation requirements and billing requirements go hand in hand. You want to ensure you have standards set to meet all requirements for reimbursement. Consistent review of policies and revision. Telehealth is constantly changing, so in order to stay current, policy and procedures need to be reviewed and updated on a consistent, agreed upon basis. Continuous process improvement requirements. Some examples to ensure that you're constantly trying to improve your program would be root cause analysis investigations, lessons learned review with teams, provider and patient survey review. Quality control and assurance. Daily, weekly equipment checks with participating sites. This allows you to proactively identify technology issues, troubleshoot and repair prior to any scheduled visits, thus not delaying patient care. Service level expectations. As stated before, this is needed to hold everyone accountable for their tasks and roles as outlined in an SLA. For example, making sure the neurologist responds to a telestroke request within the 15 minutes of being notified. Informed consent. In the current pandemic, under the waivers set forth by CMS, a verbal consent is all that is needed. We highly encourage you to obtain both verbal and written informed consent prior to every telemedicine visit. This will ensure proper practice will continue when the waivers are removed. An informed consent is good for a 12-month period for that specific provider and specific service. Renown likes to err on the side of caution, and we get an informed consent with every telemedicine encounter. I'm going to pause here if anyone has any questions on policies and procedures.
And as we're waiting for those questions to roll in, again, raise your hands, throw them in the chat box for us. I'll just add a little bit here that we've learned from experience about the need for review of policies and revisions and setting a set frequency. For us, we've now determined it's going to be every 2 to 3 years that we go through, so that we make sure that we're revising all those, and it's going to depend on what that policy is. Particularly also when we think about equipment and technology that Mike talked about last session. It's about what's that life cycle for that equipment, set that so you can make sure you're reviewing that and making sure that equipment is still current and meeting the need for now and the future. How often do you maintenance those? And that first one about compliance technology, the biggest thing we saw was with all the waivers, we had physicians reading up, and bless their hearts, they had to do their best to read up. But because of all those waivers, providers were then using whatever platform they thought they could use that they desired to use. Well, organizationally, that's not appropriate. We had to have platforms reviewed through our information security team to do a full in-depth review of the technology, the security of it, before we would allow our providers to use that. So what we learned through the process is there were many providers that read the waivers and said, well, I'm allowed to use any modality now, so I'm going to use FaceTime to connect with the patient, or I'm going to use Zoom, not embedded and encrypted through our Epic, or I'm going to use DocSeeMe, which great, during the waivers, we had to do what we had to do. But at the end of the day, we want all of our providers to use our standards so that we know it's in a controlled environment, in a way that's HIPAA compliant, and a way that we can control that from our information security perspective. So you really want to make sure that you're controlling all of those aspects, because providers are extremely diligent and smart, and they're going to look for the latest rules and regulations, but you also have to make them aware there are organizational enterprise policies specific to these type of equipment and services that we need to follow as well. So I didn't see any other questions come in there. So Jessica, I think you're probably good to move on to the next slide.
Perfect, thank you. So now I'd like to move into patient privacy and how does this apply to telemedicine? Well, the way I look at it is that this shouldn't be any different than an in-person visit. And right here at the top, I've included our HIPAA definition, which I'm sure everyone on this call today is very familiar with. It's just a reminder that this still applies even if the visit is being conducted through telemedicine. And below here are some key factors to remember when presenting a patient via telemedicine. And I know a lot of these are out there and listed, but these are some of my personal favorite ones. I was a presenter for over 4 years. So these are some of the top ones that I felt were very important when thinking about presenting a patient for telemedicine and ensuring that their privacy is protected. So the first thing is provide a safe and private space. If you're in a clinic setting, the best thing is to have a designated room specific to telemedicine, and make sure when you're in that room with that patient, you're going to always want to close the door. If there's a window in that office, pull those blinds or close that window, providing as much privacy to that patient as you possibly can. Now, if you're in an outdoor arena, such as an ambulance that might be utilizing telemedicine, always try to enforce crowd control. Make sure you move a reasonable distance away from others. Utilize the back of that ambulance. And always remember to kind of lower your voice when you're speaking over the cameras. Your voice can carry, others can hear what you're saying. The next thing is camera position. I kind of spoke about this a bit earlier. Always be aware of what that camera can see. So I know that you're looking through the camera at your patient. If I'm the provider, always make sure that what the patient is seeing of you is reflected appropriately. You don't want that patient just seeing the top of your head or half of your face. Make sure that that camera can see you from at least shoulders up and that they have a clear view of you. Be aware of your surroundings and what's on the other side. Like I said before, there may be other people in the room that you can't see. So always ask, is there anyone else in the room with you? And if you have if the provider has somebody in the room, always introduce that person, have them step in front of the camera, let that patient see that person, and then conduct your visit. Introductions. Crystal did touch on this earlier with her website manner. It's always best practice for the provider and the presenting MA to introduce themselves. That would be including your name, your title, and the location you're working out of. And also introduce the patient and anyone else that may be attending that visit with them. Always be aware of what is being said. This comes as those microphones on these devices are very sensitive, and they can and they will pick up outside conversations such as somebody passing in the hallway or a visit next door. So best practice, I've always found that if you're waiting for the provider to enter the visit, and if there's some downtime, go ahead and just mute your microphone until that visit picks back up or starts. Just always be aware of what's going on around that microphone. Answer any questions the patient may have regarding telemedicine. Remember, this is new technology for a lot of folks out there, especially our older population. They have a lot of questions regarding this. You know, is it safe? Is it secure? Can somebody be watching us? Are they recording us? You know, always take that extra minute to answer those questions and make them feel safe with this visit. Always ask for clarification. We know sometimes technology can fail or it can glitch, or there might be a lag in the relay between the two devices. So if you did not clearly hear the patient or the patient did not clearly hear the provider, always restate what you asked or what you said to make sure that they understand clearly of what's being communicated. And be aware of body language, like Mitchell mentioned earlier. You know, we can see you on the end of this camera, you know, rolling your eyes, shrugging your shoulders, having a bad look upon your face. It's no different than if you were in that room with the patient or provider. Just be very aware of that language. We want a positive experience for all involved. So once again, if you were in a room with a patient, don't act a way that you would not act if you were standing right there. Inform the provider of any visual findings they may not be able to see. This is something that I really picked up on when I was presenting patients. Remember, those providers do not see everything on that patient at one given time. So if the visit is being conducted and your eyes see something that you feel is not right with that patient, such as like increased edema in their lower extremities, discoloration of skin, or an injury or a wound that the patient's not mentioning, you know, just go ahead and say, you know, I'm seeing that the patient's legs are a bit more swollen than our last visit. And that just will key the provider into some things that they may not be aware of. Any questions on this slide?
As we're pausing to wait for questions and moving to the next slide, I'll just do a quick time check for Jessica and the team. We've got about 5 more minutes left before we want to open it up for questions. So maybe in these next ones, we can go through the billing and documentation in a summarized fashion so we can make some time for some good Q&A.
Yep, I can move through it pretty quick. We touched on it a little bit already, Mitchell, so we'll just go ahead and get going. So billing and documentation, once again, as I said before, Medicare is the standard for documentation and billing requirements. CMS sets the standard across the board, and you can reference their website for specific details regarding telemedicine. Remember, each payer may have slightly different requirements, and also each state will have different rules and requirements. CMS is the national standard. Do not forget to check on state requirements. Also remember, commercial reimbursement is dependent on negotiated contracted rates. As a presenting facility, they are eligible to bill for a Q3014 CPT code, which today reimburses at approximately $28. This is also referred to as the originating site fee. It covers the use of equipment and for the time of the individual presenting the patient. You'll want to determine the billing method best for your program. And remember, informed consent is required in advance of services. If a consent is not obtained, once again, payment may be denied for services rendered. And then please keep in mind, reimbursement rates may be tied to status of your facility. And we put some examples here: not-for-profit, educational facility, or rural health center. And as we roll into this next slide, this just really kind of goes over some of the key things that must be documented for telemedicine. Once again, here at the top, we recommend both verbal and written consent be obtained prior to this visit. Some of the billing requirements CMS requires is where is the patient physically located, who is presenting the patient, and location of the provider. And at the bottom here, you can see a sample, what we call a smart phrase, that Renown has developed that can be populated into all telemedicine visits. So this comes into our EMR, and as you can see down here at the bottom, this is the phrase that populates. And we have multiple different platforms here that when they're clicked on, we have drop-down options. So we have the first one would be which platform it's being conducted on, Zoom, Polycom, or other. You can free type in there. Using secure and encrypted video conferencing technology, the patient was physically located at, and the first drop-down would be all the different clinics and in which city and state. And once again, we have options in here that you can click other and the provider can free type into there. And then the the patient was presented, sorry, by whom. That also is a drop down. And the patient's identity was confirmed and verbal consent for the telemedicine counter was obtained. I'll go ahead and slide on into this next one for you.
Thank you. And what's important with tying this to how do we ensure adherence to policies and procedures? We looked at what Jessica just showed in the sample was what's the platform you used, right? Putting that piece in with drop downs in the other allowed us to start auditing what providers are actually using the approved platforms that we have in our system for telemedicine, which are using other. Those that are using other, let's coach them to teach them what platforms they should be using. Let's restrict that access as well. And so those are ways that we're using the policies and documentation standards to drive better adherence. But furthermore, you want to make sure that everyone understands that these policies and procedures are in place to help us stay compliant, but also be effective, efficient, and scalable downstream. That's the goal with it. And so with that, you want to establish what are your key performance metrics or KPIs, that's the referred to on this slide, to determine how are we measuring success, how are we measuring adherence. You want to get those strong physician leaders in the room to help push for this, because we know that physicians want to learn from other physicians. They don't want to hear from a technology person like myself how they should be doing their job. But it's great when you can have physician leaders that can help push this message and understand the importance of the policies and procedures and following them. Again, you don't want to make it accusatory. You don't want to make it reprimanding when you get these providers that need coaching, but you really want to give them an environment that allows them to feel participative, engaged, coached, not reprimanded for making an error, because at the end of the day, the goal is to coach them to be a proponent of the system, to help them push this forward. And at the end of the day, we have to focus on the patient and the communities that we serve. And we have to come back to why is this important? Why are we doing what we do? How is this making an impact on those communities that don't have access to care, that have social determinants that are barriers, and continue to drive that point home by using these KPIs and data metrics to enhance your program. And finally, moving to this last slide, it's about continuous process improvement. As you've heard us say multiple times throughout, technology moves at the speed of light these days, and in the telemedicine industry, policies are changing. Reimbursement policies, standards of conduct and care are changing every day. There's new white papers out consistently every month about what the best technology is, what the best benchmarks are. And so we have to continue to change and adapt and improve over time. And that's why that agile mentality, going back to what Crystal said, is so important. We don't just want to compare to national benchmarks, but we do need those. We also want to understand what's the feedback for our program specifically, and let's hear it from all of our stakeholders. I know we have listed here providers, presenters, partners, but at the end of the day, it's the entire team that delivers that care. So we elicit feedback from Mike, our IT team, from our schedulers, from our referral agents, because we really want to understand where's the opportunities to be more effective, to treat more patients, and what are the barriers for care? Are we doing a good job of addressing them? Are we controlling that quality, but actively being proactive in assessing what are the current needs? Have we done a good job of addressing those? Are the implementations we made doing a good job in meeting those value metrics we were hoping to achieve? But with that, you always want to reflect on yourself. I use this analogy a lot, is strip down and be naked is a term I like to use, but it's more be vulnerable. Look at yourself in the mirror and ask yourself, who are we actually today? And I think a lot of times we have a biased opinion of who are we and what are we doing well because we've worked so hard to make improvements that sometimes we overlook the opportunities to continue to get better. And let's make sure we're always doing that. And that's why I think countermeasures are so important, to not just say, what are our goals and targets, but also if we're not hitting those, what are the other ways we're evaluating that to make sure we can improve on achieving that target? What are the barriers that we have? And again, we want that honest feedback and reporting. So with that, I'm going to pause and go to the last slide here and open it up for questions. I know we've got about 5 minutes here left, so please ask away, raise your hand, type in the chat, however you guys would like to ask us some questions.
Great. Thank you so much, the whole team there, for sharing this with us here today. So yeah, there was a question. If a patient is doing a visit at home, what are providers instructed to do if they see activity in the background or the patient discloses information that is mandatory reporting, like elder abuse, child abuse, those sorts of things?
Jessica, do you want to take that one?
Yeah, so what I would say to that basically is that it's going to be handled the same way as you would handle it if the patient was there in person. If you witness something that is wrong, say, such as suicidal ideations, threats to hurt themselves, or if you see that the patient has been abused or you think they've been abused, you're still a mandatory reporter and that's got to be reported up. If need be, you can call to have a welfare check, to have sheriff's office go over. But then again, always remember, you don't want to treat them any differently because you're over a video connection. You want to treat them as though they're there in person. So you're going to have the same level of care for that patient as you would if they were in office.
Yeah, Neil, please unmute yourself and go ahead.
Hey, thanks for that presentation. And this is a little off topic, but I wanted to ask for the team at Renown here. I saw a news piece about some Dr. Salonen was celebrating some control center. So I'm trying to figure it out in my head, like how does that fit with what you guys are doing in working with patients and this huge room of I think it was called the control center, but I'm not sure. So I was wondering if you could comment on that.
Yeah, absolutely. And I'll say that in the final session, I'll talk about that a little bit more of an example of how we're using technology to improve patient care in the future. But what we call that is the Renown Transfer and Operations Center. Historically, you have a lot of command centers that the function is managing throughput of patients, both coming in, transferring out, working with EMS to get transport, as well as bed placement, EVS to get the cleaning and turning over of beds. What we've done is created a new center that takes that in, digitizes that. We've got 32 different 60-inch screens there. So they have the opportunity to look at all these live dashboards. So we know every patient in every bed, what the capacity is at every unit, what the requirements are, what beds are ready to be turned over, what incoming patients are there. We've co-located that to take it to the next level with some of our EMS agencies so that we have dispatchers from them there. So if we need to get care flight, helicopter, we need an ambulance on site, we're actively communicating right next to each other. And furthermore, what we believe is the future advancements of this command center compared to others around the nation is we've implemented our telehealth technology into there. And so our remote monitoring team actively sits there. We have physician provider offices built specifically for telemedicine visits there as well. And I have an office there. And the idea is that we now are taking this from controlling the care in our brick and mortars to every access point that a patient may have, knowing that with the virtual modalities, access points are anywhere in the state, anywhere in the country where a patient has connectivity to a phone. And so the idea and goal is we can now help virtually triage patients. We can help support systems in our rural hospitals to help them get the patient to the right care at the right time and the right place. Sometimes that means transfer the patient to us. Sometimes that means we're going to get a neurohospitalist on the line and deliver a telestroke to you at your hospital. Sometimes it means an ambulance is going to dial in and do a consult from the field in the middle of a freeway to determine, A, does this patient need to go to the emergency room? B, what emergency room has capacity to take this patient right now that's closest to me? And so sometimes it's about coordination of care across the continuum in the region. And so we look at that as not just a resource for Renown Health, but we really truly believe that's going to be a resource for the region to help streamline getting all patients in a service area at the right care at the right time.
That's amazing. That is incredibly amazing. Thank you for that. I appreciate getting the insight, and I especially appreciate the patient interaction that is just a small part of that. But congratulations, that was great.
Well, thank you. Appreciate the question. I look forward to hopefully sharing more about that next time.
Thanks, Neil. Other questions from the group, please feel free to unmute yourselves or write in through the chat box.
And it sounds like we'll hear more the next time of what we think is going to occur in the future. Because I know before the pandemic, there were really tight rules of where did the patient need to be located? Were they in the doctor's office? Who was on the other end? And it sounds like that in the future might not be the same. So it sounds like will we discuss that in the next one?
Yes, we will be discussing some of those. I'll highlight some policies proposed and effective that have changed since the pandemic. I'll walk us through a little bit of pre-pandemic to current state and what we're looking at post-pandemic, so to speak, as waivers are removed. And also I'll be highlighting a little bit of new technology that I'm excited for that I've seen in the area. But very briefly, I'll say absolutely agree things will be changing. There's been some permanent rules made by CMS. There are proposed changes as well. I mean, from a state perspective, I know Katie just had to drop off, but I'm sure she knows there's a lot going on that we're trying to do as a state of Nevada to open that access up for various different areas, more services covered, payment parity, amongst other things.